Welcome to the Two Curious MD podcast. I'm Dr. Alya Ahmad.
And I'm Dr. Alya Ahmad.
In this podcast, we are asking the unasked questions.
We're physicians applying the lens of narrative medicine, exploring integrative practices and psychedelic treatment in health.
Together with our guests, we weave new learnings from stories, expertise, and the sciences. With the wisdom from holistic, alternative, and these conventional medicine, we are here to challenge the status quo.
We're curious about the connectivity and complexity between diverse fields of knowledge as they relate to consciousness, chronic illness, mental health, resilience, and beyond.
Learning more about the art and science of healing, or listening to stories of extraordinary healing. You're in the right place. Let's dive in. Good evening, good day, good morning. This is Dr. Ahmad from Two Curious MDs, where two curious doctors talk about medicine, science, psychedelics, ketamine, and of course, integrative medicine, and finally, narrative medicine. So I'm Dr. Alya Ahmad.
And I'm Dr. Soraya Rahman. And we are Two Curious MDs.
So I guess the question is why one has to be curious. Why is it important to be curious? Because, what do you think about curiosity?
Well, I think we're both very curious people, and that probably goes back to our links to childhood, where we are both very curious individuals and children, always asking the question why. And I think it leads to our perspectives as pediatricians, where we're curious about childhood and well-being and what it takes to, grow and develop in a healthy way. And so I think that curiosity has led us to all these different aspects of medicine and healing, has made it very personal, brought it down to storytelling, and now to this podcast where we get to have the room to explore all these different topics and really share our expertise with our audience, hoping that there are other curious MDs as well. When I think of the title, Too Curious, it is a play on words, right? There's two of us and we're too curious. We've been told in our lives, I'm sure each of us, that don't be too curious. But here we are going, no, actually, let's be curious. Let's be just be at that edge of discovery, because as you and I are both learning, there's a lot to see and explore, and a lot that we're finding out about just all how to be healthy in this world, that there's a lot to share.
Yeah. For me, curiosity feels fun. I feel like there's so much to learn and to be curious with it, and you can enjoy kind of that learning. For me, curiosity was about why, not why, but how. Like, how does it happen? And how does one, get better at or become curious about why something doesn't work? I think, questioning the status quo, especially these days, I think we're going to have to be able to question the status quo. Like, let's get curious with that. Let's not ignore it or belittle it. Let's just get curious. And it keeps that mind open. And again, even in medicine, we talk about, especially with ketamine treatments, is let's just stay curious with oneself as well, right?
I like that. And so as we're starting out today's exploration of just how all of this fits in, let's start with just the fact that we're both moms and we're both pediatricians. And maybe I've always been asked the question, people are curious about this, going, oh, how do your kids feel about this new kind of medicine that you're practicing, called psychedelic medicine? And so I'll start out by asking you that question. What's the reaction within your kids?
For me, I have 3 kids and 3 different types of questions. One asks me, Mom, that's neat. You never would have done that before. That's my oldest, because she knows me and she knows how I was, meaning I was a really straight arrow and didn't believe in any kind of substances or psychedelics was something I would classify as a psychotic or psychotropic
Mm-hmm.
medicine that causes more harm. Um,
Mm-hmm.
and so not understanding the science at that time. My second one would be like, hey, that's pretty cool, Mom. He would nod his head and say, yeah, Mom, that's pretty cool, you got this. He's my he's my intellectual. He's the one who kind of agrees and follows and monitors, and he also is quietly a curious kid as well, but he never says that he is. He's always about kind of discovering under the zone, the
Mm-hmm.
radar zone. My third
Yeah.
child, who is 12 years younger from my oldest, so he's the youngest, and he's this big age gap. He would be like, rock on, Mom,
Mm-hmm.
and what I would see is each one has understood that and they know me. My daughter has kind of grown up with me and through my residency, and so they see this and they know that I'm not one to kind of follow the rules sometimes, and we kind of
Mm-hmm.
do have to question, and they know that, so, and trust that. So
That's
it's changed
great.
my relationship with my kids as well,
Mm.
kind of being in the mental health field, knowing that as you raise your own children, and as you raise other, and so involved in the families of children that you raise, essentially in your
Mm-hmm.
practice, you're really having, here goes one of them right now. So they seen you, they've grown up with you as well in your training and professional space.
Yeah, that's so cool. I love that even in the journey of all three kids having different perspectives, it's a kind of a little window into your own transformation as you have remained curious and open and willing to change your mind. And I think we both share that in our own training, this is not a body of knowledge that was front and center. As pediatricians, we knew a certain um, uh, few things about ketamine, for example, and that's where it stood. And I think that's true for a lot of the medical profession now. And I think that's what's behind our um, impulse to put out this podcast is to reach this audience that really is curious about it and is reading about it and seeing it on the media. However, it's different when um, you can talk peer to peer, to provide some of that, I think, evidence based perspectives that are also informed by our clinical practice. And then just our understanding as pediatricians of like what we're dealing with. So trying to solve the
Let's
problems
just
that
talk about that, what you just
Mhm.
said, the clinical practice and evidence-based. And so what is the evidence? And I kind of feel when we coming back from being working overseas, and after 10 years being away in the United States, not directly practicing in the what I call, the trenches of medicine, uh, coming back to those trenches, it was a very different trench. It was
Mm,
a trench that was filled with patients waiting for beds. It was a trench filled with people who were disgruntled, and not trusting, and it was filled with patients, on some substance of some kind or another, complicated by all of the social disparities that surrounded any condition. And so methamphetamine, I came into the Central Valley of California, and after working overseas where drugs were, there was no violence, there was no drugs, and the practice of medicine was very different. The adolescent
mhm,
practice was very, very different. But so coming back into a new paradigm of mental health and the crisis really was a crisis. I kind of landed and I felt like I was in a foreign country.
mhm. Yeah, it does feel like a war zone. I think both you and I have worked in the hospital, in the trenches, as you said, at the front lines where we see parents and kids just waiting for days for placement for a mental health emergency, and that's just even gotten worse. So I think this leads us very nicely into the presentation you have um, that
Yeah.
that on ketamine. So maybe we can go there and start. to unpack the psychedelic medicine realm of healing that we find ourselves at, this intersection. Take it away. And I
Take
can
it
give that,
away.
yeah. Go ahead.
Yeah, so this is about ketamine-assisted psychotherapy. It doesn't just have to be about ketamine, but it can be about psychedelic-assisted therapies, integrative medicine, your mental illness. This is the two curious MDs, and we're opening up the realm of psychedelic medicine, right? And what that realm of healing is going to be like in practice of medicine as well, conventional and integrative. So I'm Dr. Alya Ahmad at ShaMynds Healing Center. We're www.shamynds.com. And of course, Dr. Suraya Rahman in Southern Cal, Pala Medicine, www.palamedicine.com. Look us up. Plenty of resources on our websites about this kind of approach and treatment and philosophy. So let's talk it. And what's your
Let's
question
go
now?
for it. Oh my gosh, why is mental health in such a crisis right now? You talked about this place you found yourself at when you came back into the country. So you recognize that, oh, this is not where we were before, and we are in a different place right now. So what to you is the components of that crisis?
Well, in my opinion, I think it has to do multiple things. One is, the whole system of conditions became much more recalcitrant. We're talking about comorbidities attached to mental health conditions. We're talking about eating disorders attached with generalized anxiety, with trauma. And then that also again, gut issues. Inflammation, recurrent admissions. We're talking about comorbidities like obesity and the again associated increase with and depression, anxiety, and the like. I think COVID was a big factor in really uplifting the surface of what was underneath the volcano. It just really erupted
Mm-hmm.
through that. Um, and I think it was just became very apparent from household to household, right? Within the household
Mm-hmm.
itself. I think it's also important to talk about us as healers in the health space, witnessing after 26 some years, observing kind of the whole shifting of healthcare and how we're losing that touch, that human touch, and this connection in practice that's often felt because of we're really governed by the system and the insurance processes and the timing and 15-minute appointments and and then the effect that we when we experience even in our training the that whole development of the physician who comes in very wide-eyed and bushy-tailed and leaves
Mm-hmm.
beaten down and mistrusting because things are not as clear and clean. We're all wounded
Yeah.
healers. Um,
Yeah. Thank you for bringing that. I think that's what we share for sure in our journey towards this idea of how to understand that, leading us to narrative medicine, right? And how we did that healing for ourselves, and even calling, labeling it the wounded healer is something that's not accepted, or is kind of stigmatized still, and recognizing that when our patients suffer, we suffer, and we're both patients and healers stuck in a system in which the suffering of, especially with mental health conditions, but the suffering of both parties is occurring and ongoing. And COVID, you're right, just you know, drove that into the forefront for the both of us, I think. And that's when we think, just a year apart, decided that we were going to enter into this practice, kind of unbeknownst to each other. We only met a couple of years later, but I think
do
we're
you want to
both.
explain a little bit
Mhm.
about narrative medicine? Because I think for the audience,
Yeah.
that term comes up, and often the question is, well, I've heard of that, but what is this really? So let's talk
Oh,
about narrative medicine.
Yeah, it's an interest we both share. It's you went to Columbia to do the master's in narrative medicine with Rita Sharon, who coined the term, and she was looking at just this picture, right? This picture that you have on the slide of the healer and the patient sitting next to each other, and what occurs in that experience, and treating it as an experience, and as in recognizing the metaphors, right? Recognizing the languaging, recognizing the context that's occurring around the patient and the healer, and how that is leading to well-being or not. Um, and narrative medicine is a very interesting set of skills too, to recognize and then respond to what's going on. And so even in situations where there may not be a right answer medically, that, especially end of life situations or trauma situations where we're dealing with very difficult things, we're asked in narrative medicine to go towards this understanding of, okay, well, we can still make some meaning out of it. We can still recognize it. We can still hold it and develop skills with which to hold difficult things that may not end with a prescription being written or a procedure
Right,
being done, and
right.
yet are still meaningful, right?
Mm.
And so I think narrative medicine, in the TLDR that I talk about, is like back in the day when doctors and patients got a lot of contact with each other and the system wasn't running the show, the relationship took front and center. And now we are kind of having to backdoor in the skills of relationship back into medicine. And narrative medicine is one of the ways that we grow that aspect.
Yeah, you're absolutely right. I had to teach narrative medicine to third and fourth years at UCSF, and I was training, working there. It was profound to me that, and it became apparent then the understanding of what is, the definition of compassion and empathy, and how do you hold space with a patient or witness that condition as it manifests in the body and it manifests in the system, the impact that can have not just on the person but on the whole surrounding of that patient. I call it the context of care. And
Mm.
how do you hold space for that? How do you even understand a medical condition? And the story of the illness has to kind of be basically understood as well. And we tend to be very
Absolutely.
checklisted in our history and present illness. We really become, yeah, is it this or is it that? But really, engaging with a condition in element of story, and how that
Yeah.
can be better understood and better treated, because sometimes it's not about the headache. It's what led up to the headache that's more important,
Mhm.
right?
Yeah, yeah. I really like what you mentioned earlier also, in an earlier conversation, the idea of asthma, right? I used to always teach that no two asthmatics are the same, because they both may live in completely different neighborhoods
Right.
and have completely different genetics and have completely different education about it, or even access to good food, clean air, um, a lack of pollution and all of that. And there's not a lot of place in our discussions in medicine about how these factors can impact, and why it's important to recognize them and what impact that has on the healing process.
Yeah. And they don't have to be complicated. These are methodologies that are um, you know um, learnable, teachable, and
Hmm.
implementable, because they're simple questions that you with just curious questions that you can come up with in terms of, for example, pain. um,
Hmm.
what is that pain? Where is that pain body? And what describes that there are different types of pain. So draw me a picture of of,
Hmm.
of pain in your body, and color it. Be creative with what that represents as you feel it, and then talk
Yeah.
about pain. I mean, I had this one patient, and I had to really have her draw out her feeling body map in
Hmm.
her body to describe her reflux pain, and which was very different, ulcerative colitis, than her CRPS pain, than her
Hmm.
pain that she had from an injury, or a pain that she had from a headache or a migraine that results from this whole course of action. And but it is, because we when we talk about pain scale, we say, well, what is your pain like today? And it's 10 out of 10.
Yeah.
You really understand where that pain lives.
I think our audience may recognize, and some people in the audience may be in the healthcare field and recognize how one-dimensional that pain scale is, right?
Right.
Um, it erases the meaning of the pain, it erases the origin, the story around it, the resiliency factor, and really boils it down to a numerical scale just for the purposes of giving medication or not. And
Right.
that's just so reductive, right? So we're here kind of being anti-reductive in some ways and expansive.
The other
And
thing I
mhm.
noticed coming back was the the efficacy of medications just was so much
Mm,
less. We were so excited in the early 80s, 90s, I think, when SSRIs came out, and we were talking about, wow, the new wonder drug. And now, over the course of time, we're seeing that SSRIs are, and all the hype is not what it was meant to be. And so we're talking about real world data now, and we're
mhm,
not seeing that remission. And I'd like a little bit for the audience to kind of understand some of the research behind this. The STAR-D trial is something talked about in mental health space, right?
mhm,
That it's a long multi-center national study conducted over several years, looking at the likelihood of benefit of treatment when you're talking about first line treatment for depression. The efficacy is only about 27%, meaning 27% of your patients are going to go into remission in that first line of treatment. Okay, maybe that's a good number, but when you move on from first line to second line to fourth line, your efficacy diminishes down to about 7% by the time you hit fourth line treatment. So that means 93% of people are not in any form of remission, not even close. And that the likelihood of them discontinuing their treatment over the first line, second line increases in general overall, right? We're talking about 41% of patients by the time they hit the fourth line treatment will stop the medication, either due
mhm,
to a side effect or this story that I'm treatment resistant and nothing is working
mhm.
on me.
Yeah, what a stark kind of story here that as we get further and further away from further and further into the diagnosis of depression, the longer that depression lasts and it doesn't get treated, not only are we developing quote unquote treatment resistance, but what does treatment resistance mean when you're talking to the patient? It may mean despair. It may mean they've given up hope. It may mean that now this is who they are and they can't recognize who they are outside of this condition because it's become so difficult to treat, and there might be side effects, and there's the labeling and all of that. And I think there's this interesting idea that you have to be um, sick enough to get the treatment, and you
Yeah.
have to continue to be sick enough to get the treatment. However, what we know, what was once a condition, depression, that used to traditionally be treated, and the expectation was that this was episodic, has now become a chronic condition. And I think we recognize that the function of the pharmaceutical industry in promoting the chronicity of this condition and throwing more and more of the same but different medications, at the problem, has left a big gap in the possibilities of treatment. And I think that's the part that we are really um, serving here as we step into this new world of rapid antidepressant treatments through psychedelics and other medications.
And I'd
Um,
like to pause here too, and
mhm,
really reflect on the story of illness, right? The context of care. We talk about, this treatment resistant, and even question and be curious about what is treatment resistant really mean, and what
mm,
does this and how is this represented in the story of that illness?
mm.
What do you think?
Oh my gosh. So we know that the longer we wait to treat depression, or the longer it takes to bring it under remission, um, the depression becomes more and more treatment resistant. To the extent that trials have now, before treatment resistance used to be defined with much more strict rules of, oh, you've got to have failed three. medications to be to qualify as treatment resistant, so you can qualify for treatments for treatment resistance, right? And the recognition that the one of the main factors of why something becomes treatment resistant is when depression has just hung around for long enough and has kind of become more and more stabilized and isn't responding
So who is
um,
resistant?
to
Is the
right. Who is
patient
the resistant? Right,
who is
right.
resistant?
You're getting down to the
Is it the
word of it.
patient who's resistant to the medication, or is the medication
Right,
resistant to the patient?
right,
And we're
right.
talking about,
Absolutely.
you know, so this is where you have to think outside the box.
Yeah. And
And
this is also a point of narrative justice, right? This
yeah,
is where we can really point out that who is resistant and how are we languaging around
yeah,
resistance and who are we blaming?
yeah.
You know, who's being blamed for this quote unquote failure
Mhm.
has been now nicely packaged into this label of treatment resistance, but we're not going to say, oh, we have ineffective treatments,
Yeah.
right?
Or even the
Or
doctor is saying you're treatment resistant. Like I can't do anything for you, right? it
right, and
becomes it becomes a patient's
yeah,
problem. Not only is a patient
right,
feel like they're broken, that they're nothing works,
yeah,
we're actually even establishing that and highlighting it that you're just treatment resistant and there's nothing else for
right,
you. So
right,
and
exactly, and
that's
how,
that really is in the context of care.
hmm
And I think the care paradigm, right, between the doctor and the provider, or the patient and the
yeah, it
provider.
leads to a lot of futility, a lot of, broken relationship, a lot of, as we see, healthcare trauma, a lot of loss of hope. Um, Absolutely.
And this aspect that these medications are FDA approved and have come, and the efficacy's been, I think this book called The Emperor's New Drug talks a lot about the clinical trials. Once in the Freedom of Information Act, we're able to really open up the non-published data on SSRIs and SSNRIs with randomized placebo-based control studies. And this is just opening up, not just looking at what is published, but not published. And
Hmm.
now looking at your data on efficacy, um, no better, no better than placebo,
Yeah,
and
yeah,
and no better than other tricyclics as well.
yeah.
So
Which
I'm
goes to this idea that SSRIs have really flooded the market. Like the so much energy has been placed in marketing the SSRIs and cherry picking the data. Only now, 10 to 15 years later, where we see the real world um, kind of impacts of how these medications work, and also have grown our model of what depression really is. This now seems like, it took up a lot of the room, a lot of the investment in pharmaceuticals when it came to mental health treatments, and that may soon need to shift. And we're in the midst of that shift,
right. And I
right?
invite our audience to really Google these things. These are things that we don't necessarily talk about in conventional medicine.
Yeah, the book that you're mentioning is called The Emperor's New Drugs by Irving Kirsch. So highly recommend that you read that if you're interested in this topic.
I wanted to talk a little bit about, a lot of times our focus is medicine, and we tend to get like drawn into just the medicine. But I'd really like to talk a little bit more about the set and setting and that relationship that one has in behavioral health with the doctor, with the therapist or other behavioral health specialist. And again, going back to the context of care, right, to depression, what is that set and setting like for that patient in the context of that condition that they live
Mhm.
in, and the set and setting of that context of care where patient seeks support or even treatment.
Yeah, and I think a lot of the randomized control trials miss this information, right? They're not looking at this.
No.
There's not a lot of awareness of the relationship between the therapist and the client, for example, and how that can lead to effectiveness in addition to medication, and how by just focusing on the medication, we've kind of left those behind. And so I think what you have here is the psychotherapeutic model for psychedelics, that a non-ordinary state of consciousness that really helps us to realign that relationship um, of, okay, what is really happening here? Yes, there's medicine, but there's also the relationship. There's also that context of care that you talked about, and the story that's
Right.
being.
And that story of that condition
Mhm,
and really allowing for an expression of that story, right, of depression for the patient who, and then that therapeutic alliance that is the first step to any kind of treatment approach. We tend to, as doctors, jump to treatment, but without really fully understanding first that set and setting, and then second that alliance that you often need with the patient. It isn't about what you subscribe to or prescribe to. It's really about having them invite into that conversation of treatment for themselves, what they seek, what they, something that would be work for them.
mhm.
And in any type of treatment, there has to be some preparation, even in conventional medicine, when we talk about really building in our, as we do in pediatrics, really see the family and the child grow and anticipate, and so you're really prepping them for their treatment for that visit, but also for their next upcoming type of care. Um,
I think that might be a reason why more and more pediatricians go into this, because we actually think systemically, and in this kind of mindset of relationship and trust, and that container of safety that needs to be held. So yeah.
well,
All right.
what do you think about ketamine? What
Oh my gosh.
ketamine as a treatment for
So
you?
here I was, in the trauma center doing moderate sedations with ketamine and other medications for painful procedures. And I had no idea that ketamine is at a lower dose as a psychedelic. Only um, more recently did I become aware of the research that's been around since the 90s. Only recently did I kind of understand that it's even um, safe to use in the office setting, and all of that information. So I'm really excited to share this part of the conversation, because I think this is something that a perspective that isn't um, widely known in the medical system. However, it's becoming more and more known,
Yeah.
and so I think there's a lot of curiosity about this part. So um,
Yeah,
you know.
instead of being a dissociative anesthetic, right? You think about it being a
Mhm.
dissociative anesthetic that also causes hallucinations. So yes, even in my practice, little did I know that while you're suturing somebody and they're having, talking to you in the ER, that they're actually having a very therapeutic discussion with you. And you're often sitting there going, wow, yeah, you're right. And then you have this beautiful conversation that's a very relaxed, semi-relaxed setting, because you have this certain bond that you have when you're taking care of them, and they have
Mhm.
um, and they're dissociated, and they're talking about sometimes seeing balloons and flying elephants is what I remember one patient told me. So yeah, it is a
Yeah.
dissociative anesthetic. It's used commonly in emergency rooms, and especially in children for short procedures. And
Mhm.
yes, at the sub-anesthetic dosing, it is a psychedelic. Schedule 3, of course, controlled drug substance. It's regulated heavily by the DEA for good reason, and a commonly used anesthetic in battlefield. This is really where kind of it came up
Mhm.
as a rapid acting, safe anesthetic that didn't require airway support.
Right.
During Vietnam War is
Exactly.
really when it. Go ahead.
Exactly. Exactly. We're hearing so much about ketamine in the news, but we don't really hear about how safe it is in trained hands. And the safety profile of it is what made it safe to use in children, and also, yeah, to administer it as a quote unquote buddy drug, right? That's what it was
Yeah.
called. You break a leg out on the battlefield, you get a shot of ketamine, and you'll be able to still breathe on your own and
Yeah.
still be transported to the next level of care. And that was very useful. So yeah. Mhm.
So the evidence on its treatment for multiple conditions, right, in mental health, seen in severe and chronic postpartum depression, suicidal ideation, bipolar depression, post-traumatic stress, OCD, and some substance use conditions as well.
Absolutely.
I bet you're wondering now, how does it
How it works.
how
Go
does
for it.
this work? in the brain? What is it actually doing? What do you think?
What do I think? Oh my gosh, it's crossing the blood-brain barrier. Um, I think when we think about what's the perfect medication to use on somebody who is in a mental health state, right? Right now, what we have are the antipsychotics. If they're having a crisis, we give them a medication that just sedates them, and that's it. It just kind of puts a blanket on the fire and calms everything down, and then the person goes to sleep, and then they emerge and they still have the condition. Here, we're actually causing an excitatory glutamate surge. Your blood pressure is increasing, your heart rate's increasing. There's this upregulation of these receptors, more synaptic proteins. There's actually brain-derived naturopathic factor BDNF being released, which is the factor we know that leads to greater neuroplasticity. Neuroplasticity meaning more new connections being formed. And then we know that the metabolite hydroxynorketamine actually has an antidepressant effect, a rapid antidepressant effect. And so this is a whole different paradigm. You can give a medication to somebody, and within one dose, they might um, cease having the suicidal ideations that they might have been having just before you gave them the medication. Um, they might, you know, um, have a remission of their depression symptoms. They might just have relief of their pain that they're carrying, right? And all of this is happening, and they might have an increased ability to grow new pathways in their brain. So, what we're seeing in depression, for example, is this idea that the pathways in the brain kind of get overdeveloped in one direction. The negative thought patterns just really become very um, set, right? And here we're saying that, oh no, you can actually build different thought patterns. You can actually learn. And so I think this is the fascinating part for me, and I think for you, is that it's bringing together learning, is bringing together the idea that the brain has the ability to shift on a systems level. If we can harness the power of this medication and also combine it with psychotherapy and relational healing, and that we get the boost of the antidepressant effect, which is really cool because then they're able to help themselves more. And it's immediate, it's rapid, it's happening on a hours to days basis,
So this
which is quite
this
amazing.
activation, say this ketamine is an NMDA antagonist, right? It
Hmm.
blocks glutamate. This glutamate release causes this
Hmm.
GABA disinhibition. So whatever is holding the brakes, the frontal
Hmm.
cortex, the executive functioning, whatever's holding that activity is quietened, right?
Hmm.
And not only does it work at that receptor, the upregulation of the AMPA receptors, which is now we're working at production level, where we're able to
Hmm.
increase synaptic neurotransmitter production for other neurotransmitters. And of course, I have to talk. Ooh, look at those balloons. I have to talk about the activation of
That was mind blown
that
right
was
there.
mind blowing, right? Woo!
That is pretty cool.
BDNF. The first
Hmm.
time I ever heard of BDNF, I was at Baylor. I was doing research on the actually it was the GABAergic system, but in the hippocampus. And my job was to kind of help dissect out the hippocampus in rats and take the hippocampus and plate those cells, those neurons on a plate and
Hmm.
grow them. And basically incubate them so that we could test those neurons with acetylcholine, nicotinic. It was that receptor or neurotransmitter system. And when I used to plate them, there was a little bottle of BDNF. And I would actually sprinkle it onto the petri dish, the growth factor. So
So here you are doing
here
that
we are
now
talking
in the
about ketamine
clinical realm.
increasing BDNF, and the activation mTOR. And of course, as you talked about, the secondary metabolites of ketamine, which is a hydroxyketamine, which has this extended 7 to 14 days of antidepressant effect, depending on how it's metabolized in that body, right? Yeah, so, and plasticity. I love this because I think what we were often told in medicine is that the number of neurons you get is the number of neurons you get. And then the rest, we're only losing, but this aspect of regeneration. Chronic stress is also very, very inflammatory and can be seen on EEG readings, so you can actually see the evidence, the inflammatory waveforms that are also there on a stress brain, and the atrophy effect, the loss of synaptic response, the retraction of neurons, and ketamine then having this, and other psychedelics also having this ability to really treat and support this chronic stress brain, and regenerate in dendritic budding. This is a picture, an electron micrograph of a rat brain before and after ketamine, and this is within hours after. Of course, they have a faster rate of regeneration, where you can actually see, before ketamine and after ketamine, same, what the amount of dendritic budding that's seen post infusion. Of course, we don't have any human studies here for obvious reasons.
Yeah, but here we are, that's the mind-blowing slide right there, is we can actually see evidence now in electron micrography of exactly what we're talking about, which is that I always describe this aspect to my patients as, well, you imagine a plant, right? The brain's kind of branches and root system and everything, it follows the kind of ways that a plant grows. And imagine a plant that you have in your home that just doesn't have enough branches, right? And sometimes what do? We cut it, we prune, we trim to increase the number of branches. And so and we do that because we know that when there is a plant point of growth, that some sort of growth factor, right? When we cut it, some sort of growth factor arrives at that place in the plant and it allows it to grow new branches. And so that's a phenomenon that we can see happening in our real world, everyday world. And that's a similar phenomenon that's happening in the inner world, in our brains, which we can't yet see, but we can see in the rat model, which is just really fascinating and changes the whole idea of the fact that the adult brain cannot learn.
Right.
Yeah.
Hallelujah. So I want to pause here because I know there's more questions, and I want our audience to really, take this in. This is a lot of information. We provided you the references. Look it up. Do your research. I've been in this practice for now over 3 years, and you too, Simi, have been in practice for some years now and seeing kind of this transformation. But my question to the audience is, who is treatment resistant? What is treatment resistant really mean? And why would this ketamine or psychedelics be an option for a treatment resistant condition? Or should it be an option in general, right? As possibly first line treatment, if we can see the efficacy of this.
Right, you're jumping ahead 2 moves.
I have questions,
right?
and I think I want the audience to really, ask themselves these
Yeah,
questions.
yeah. So the question is, why are we saving this mode of treatment for only treatment resistance, when really, if we're looking at the model of depression as a chronic stress on the brain, and not just the serotonergic model, right? There's treatment resistance in the serotonergic model, but if we think about it in the systems model of depression, where we're talking about the context, the nutrition, the inflammation, the environment, the relationships, and then we're talking about the brain and what's happening in the brain. And we have a medicine that can actually help with increasing the connections in the brain. And what we see with those increased connections can be self-efficacy, improvement in thought patterns, improvement in relationships, improvement in the energy and motivation to engage in some of the habits and behaviors that you want to grow, And so we're seeing that this is a practical tool that becomes very useful, whether you're in the first 3 months of being diagnosed with depression or, 30 years down the line, and you've tried everything and you're kind of reaching for ketamine as a last ditch effort. So I think we're kind of recalibrating what's the story here of ketamine and depression, even because we're being told one story, but that we know from narrative medicine that the single story is a dangerous story, right? We should
Yes,
always go
the
with
danger of the single story.
right, the
It is
danger of
not
the single
usually fun.
story, quoting
So many
Chimamanda
stories.
Adichie Ngoche in her talk,
Yeah,
saying that we do a disservice. Absolutely,
yeah.
yeah.
So again, for our audience, what makes a treatment resistant?
Mm,
What are the top things that make something resistant? Who is resistant? The
mm,
patient or the medication or the options? And what else can we do? What else can we do
yeah,
outside of this to
I
really
love that. If we get out of the,
resistance?
yeah, sorry to, if we get out of that mold of thinking of treatment resistance, we are breaking in a way the thought patterns that get stopped, right? When we
Right.
say somebody's treatment resistance, we stop thinking about it. We stop thinking of the possibilities of how to blast through. But if we can retool that and understand that it's a language problem too, as you're describing, who is treatment resistant, right?
Yep.
Um,
It
and
is.
recognize that as a language problem and not really a patient problem, then the possibilities can maybe open up again.
Yeah.
Um, I love that.
Thank you.
Wonderful. Yeah.
Thanks for joining us on the Two Curious ND podcast. We hope today's episode inspired you to ask new questions and explore fresh perspectives. We challenge you to ask us those unasked questions that you're curious about in your medical practice, condition, health, and wellness.
If you enjoyed the podcast, don't forget to subscribe, share it with somebody just as curious, and leave us a review. It helps us keep the curiosity alive. Post or comment with a question or curious inquiry that you have and seek to explore or learn with us. Stay curious, and we'll see you next time.